When it comes to caring for your patients, every detail matters. Knowing the numbers, trusting the diagnostic process, deciding on the right treatment when it matters most. Learn more at atrubihcp.com and see if Attruby is the right treatment for your patients. Please see full prescribing information for Attruby at attruby.com/PI. Brought to you by BridgeBio.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hello, CardioNerds. Before we start this episode of the CardioNerds Pulmonary Embolism series, I want to give you a quick disclaimer. We recorded this discussion before the HI-PEITHO trial results were released, so you'll hear us talk about HI-PEITHO as an upcoming study. Since then, the data have been presented and published, and they meaningfully advanced the evidence for catheter-directed thrombolysis in intermediate risk PE. HI-PEITHO was a multinational randomized trial of 544 patients with acute intermediate risk PE, all with RV dysfunction, elevated troponin, and additional markers of cardiorespiratory distress, but without overt shock. Patients were randomized to ultrasound-facilitated catheter-directed fibrinolysis with low-dose alteplase plus anticoagulation versus anticoagulation alone using a standardized ECOS protocol. The primary endpoint was a 7-day composite of PE-related death, cardiorespiratory decompensation or collapse, or symptomatic recurrent PE, adjudicated by a blinded committee. The trial met this endpoint. Events occurred in 4% of patients in the catheter-directed fibrinolysis arm versus 10.3% in the anticoagulation alone arm, a relative risk of about 0.39. This benefit was driven mainly by fewer episodes of cardiorespiratory decompensation, while early mortality and recurrent PE were low and similar in both groups. Crucially, this reduction in early clinical deterioration did not come with a clear major bleeding penalty. Major bleeding at 7 days was 4.1% with catheter-directed fibrinolysis and 2.2% with anticoagulation alone, a non-significant difference, and there were no intracranial hemorrhages in either arm. So as you listen, keep in mind that our conversation reflects the pre-HI-PEITHO uncertainty. HI-PEITHO now provides randomized evidence that ultrasound-facilitated catheter-directed thrombolysis can reduce early clinical deterioration in carefully selected intermediate risk PE patients without a clear increase in major bleeding, though it does not show a mortality benefit and relies on a composite endpoint that heavily weights cardiorespiratory decompensation. It moves catheter-directed thrombolysis closer to an evidence-based option for this population, while ongoing and future trials will continue to define exactly where it fits in practice. With that context, let's get into the episode. Welcome back, CardioNerds. This is Dinu Balanescu, Rising Interventional Cardiology Fellow and current General Cardiology Fellow at the Mayo Clinic in Rochester, Minnesota. We have another exciting episode in our Pulmonary Embolism series as part of our ongoing collaboration between the CardioNerds and the PER Consortium. Today, we're looking forward to discussing the topic of the golden age of pulmonary embolism RCTs. Without further ado, I'll kick it out by introducing our team. We have one of our CardioNerds PE series co-chairs, Dr. Joe Mullinax, who's an interventional cardiology fellow at Emory with particular interest in PE management and complex PCI. Billy Joe, take it away.
Hello again, Dinu. I am thrilled to be back with you again and with the CardioNerds team. It is such a pleasure to be a part of this ongoing pulmonary embolism series collaboration and to introduce our fit lead for this exciting episode, Dr. Shiavax Rao, who is a vascular medicine board general cardiology fellow with Guthrie Medical System in Pennsylvania. He's also one of our first-year trainee council members and a fellow CardioNerds enthusiast. Welcome, Shiavax.
Thank you, Dinu, and thank you, Billy Joe. It's a pleasure to be here today with the team at CardioNerds. Today, we're incredibly fortunate to be joined by Dr. Giri. Dr. Giri is an interventional cardiologist, clinical investigator, associate professor of medicine at the Perelman School of Medicine, and the director of the Cardiovascular Catheterization Laboratories at the Hospital of the University of Pennsylvania. His work has helped shape how we think about pulmonary embolism at an international level. He's a leader in advanced PE therapies, clinical trial design, guideline development, and multidisciplinary PE response teams. And he's been at the forefront of bringing high-quality, randomized evidence to a field that's long needed it. Dr. Giri, thanks so much for joining us today on CardioNerds.
Thanks so much for the invite. I'm really looking forward to a conversation.
Let's start this discussion with a case that I think many of our listeners will recognize. Mr. Pete Klopman is a 62-year-old man who presents with acute onset dyspnea and pleuritic chest pain. He's tachycardic but normotensive. A CTA of the chest demonstrates a large bilateral pulmonary embolism with significant clot burden. The RV to LV ratio is 1.2, and cardiac biomarkers are positive with an elevated troponin. So by contemporary definitions, this is intermediate high-risk PE. The patient is not crashing or hemodynamically unstable, but clearly not low risk either. He started on therapeutic anticoagulation, and a PERT activation is triggered. And now comes the question that generates debate on rounds and in PERT meetings. Is treatment with anticoagulation alone enough, or should we be thinking about an advanced therapy? Before we even get into the trial data, Dr. Giri, can you walk us through how you conceptually think about advanced PE therapies in a patient like this? What options exist today, and how do you make that decision at the bedside?
So broadly speaking, the history of management of this patient is clear. It's early anticoagulation that transitions from parenteral anticoagulation with unfractionated or low molecular weight heparin, and then transitions nowadays to a DOAC, which continues for an amount of time that is determined generally in the outpatient setting based on a number of factors, including recurrence risk scores, biological sex, and other risk factors. However, where we're at right now in an era over the last 15 years where many advanced and active clot reduction therapies are being considered. Although that's come to the forefront more recently, it's important to recognize that active clot reduction therapy is actually an old concept. And there's one clot reduction therapy that has been extensively studied. And for a long time, actually, there were 16 randomized trials of this therapy performed over a course of 40 years between 1972 and 2012. And that's systemic thrombolysis. Nearly 2,000 patients have been randomized to either anticoagulation alone or systemic thrombolysis, exactly in the condition that you just mentioned, what we currently term intermediate-high-risk PE by ESC guidelines. So what do we know about that set of trials showed? How does that inform us on where the field has gone over the last decade? Well, those trials overall demonstrated a couple of important facts. First of all, the systemic thrombolysis is actually effective at improving RV function and reducing PA pressures acute. It also seems to be effective at rescue therapy in those patients who are decompensating compared to those who continue to be treated on anticoagulation alone. So the question becomes, if that's been demonstrated, randomized trials have even shown decreases in decompensation, and believe it or not, even in absolute mortality in these randomized trials that compare to anticoagulation alone. Why is it that systemic thrombolysis doesn't carry a higher guideline recommendation in the exact patient you mentioned? Well, it's because of the trade-off. And despite the fact that it looks like when you meta-analyze trials of systemic thrombolysis that we reduce mortality, we also dramatically increase some risks that some people might say worse than death. And the biggest one is intracranial hemorrhage. So with systemic thrombolysis across the board, spontaneous intracranial hemorrhage ranges between 1.5% and probably 3%. In randomized trials, it's been closer to 1.5%. And larger administrative registries and data sets, it goes in the 2 to 3% range. So the issue here is that you've got this big risk of intracranial hemorrhage. And then, of course, other risks of major bleeding off target that seem to come to the fore in the randomized trials and in the observational studies of systemic thrombolysis. The second piece is, well, you could say, okay, those are major risks, but you just told me there might be some benefits to systemic thrombolysis of improving mortality, and surely it might be worth accepting those risks to improve mortality. But the problem is, while the meta-analysis demonstrates that mortality improves, the issue is, what's the absolute improvement in mortality? And that absolute improvement is small. It's in the 1 to 2% range. So I just told you that there's this trade-off of maybe a 2% risk of intracranial hemorrhage, but at best, you're getting a 2% benefit in mortality. So it's thought that this balancing act is quite close. And that has led prior guideline committees to judge this as a very tough call, and one where they can routinely recommend systemic thrombolysis to every patient coming in the door with intermediate risk PE, because while you may help some people, you're certainly going to hurt a lot of people too with bleeding and intracranial hemorrhage. So this background of all of the study that was done over 40 years of systemic thrombolysis, intermediate risk PE, is just a really important kind of predecessor to what has led to a lot of interest from a lot of parties in whether there's a better way to treat these patients. Because the bottom line is, when it comes to intermediate risk PE, we do have a number of issues that we worry about for the patient. Primarily up front, it's, can they decompensate? And that range of clinical decompensation, depending on the study you look at, ranges between 2% to maybe 10%, depending on the population that's been studied, what hospital they're at, and where they are on the intermediate risk PE spectrum. So you want to prevent that decompensation and potentially mortality associated with that. Additionally, these patients are quite symptomatic. In a perfect world, we'd love to return them to a very good functional status earlier. While it hasn't been perfectly proven that active thrombus reduction strategies in a randomized fashion do that, there's a lot of observational data to suggest actively reducing clot burden does improve symptoms of PE faster and allow patients to return to good functional status faster. It obviously makes common sense to think that since these same therapies have been associated with definitively more rapid improvement in RV function and reduction in PA pressures and decreasing from an absolute standpoint, the total amount of what we call residual pulmonary vascular obstruction in the lungs. So you want to have this benefits ideally of preventing decompensation and getting better functional status earlier. Final thing that you may also be able to benefit is longer term function. And that kind of goes along with the second point I was making, which is functional status. But we also want to think about those patients who suffer from what we call now the post-PE syndrome. It's a larger group of patients than those who just manifest true CTEPH or chronic thromboembolic pulmonary hypertension. Those may affect 3 to 5% of incident PEs. But there's maybe a much greater group of patients who have intermediate risk PE who have persistent decrements in their functional status due to dyspnea and exertional intolerance. This could be 25, 30, 35, 40% of all patients with intermediate risk PE or hospitalized, depending on the series you look at. They don't have frank CTEPH that you can diagnose on an echo or with an invasive right heart cath. But frequently, if you actually test them with formalized cardiopulmonary exercise testing, they, at least observationally, are, from an age-adjusted standpoint, are performing very poorly, below the 10th percentile, and in some cases below the 5th percentile for their predicted age and biological sex. So we're in an interesting position here where we want to make these endpoints better, but we want to do so with far less risk than we expose people to with systemic thrombolysis. And that's the key aspect of what all the interest around interventional therapies for intermediate risk PE is.
So we actually do have solid data on some of these advanced therapies, such as systemic thrombolysis, but in this particular situation, perceived bleeding risk may intimidate clinicians, and the studies may have just had suboptimal endpoints. But the landscape of PE-RCTs is not as barren as many may feel anecdotally. Now, catheter-directed therapies, including catheter-directed thrombolysis and mechanical thrombectomy, however, although have solid observational safety and efficacy data, are still victims to the critique that there are no randomized trials for these therapies. Now, furthermore, level 1 guideline recommendations are still lacking, but that narrative is starting to shift. And Dr. Giri, I must admit the title of today's episode is chosen very much intentionally, as the phrase the golden age of pulmonary embolism randomized controlled trials is coined by you. So could you please walk us through what you see as the most important RCTs to date in PE and why do they matter for clinical practice?
Sure. I'll start by giving just a slight preamble to state that there have been some randomized controlled trials in the intermediate risk population for interventional therapies. And broadly speaking, when we talk about interventional therapies, we're talking about two different approaches right now. One is catheter-directed thrombolysis, which is the placement of catheters into the PAs with alteplase or tenecteplase usually dripped in over a period of time. And there have been varying strategies for that, 2 hours, 4 hours, 6 hours, 12 hours, 12 hours by far the most typical. And then the second group of therapies, which you alluded to, is actual mechanical thrombectomy therapies. And there are a variety of different devices that exist for that. For ease, we usually group those into large bore mechanical thrombectomy devices, so big devices that go in to suck out clot or suck out clot with adjunctive devices to mechanically remove the clot, or moderate bore devices, which are still reasonably large compared to most catheters used in the cardiovascular space. Broadly speaking, we think of large bore devices as being 20 French or greater, some would say 16 French or greater, and moderate bore devices being more in the kind of max 16 French range, kind of the accepted nomenclature right now. As far as what the preamble I was mentioning is, there have actually been 3 randomized trials of interventional therapies for PE that have been completed. I should say 2 are truly completed. 1, unfortunately, was halted early. The first was Ultima, and Ultima was the first trial of catheter-directed lysis for intermediate risk PE. And it was a trial of the ECOS catheter, which is an ultrasound-assisted thrombolysis system, so a specialized catheter to ideally deliver TPA and potentially also have some sonication benefits to disrupting clot as you're delivering the TPA. It was ECOS in one arm versus anticoagulational in the other arm, and it was just 60 patients that were studied, and the primary endpoint was those surrogate endpoints, improvement in RV function, with also PA pressures being looked at. The trial was positive in the sense that the 48-hour RV improvement was substantially better with the use of ECOS TPA than it was with anticoagulation alone. But at 90 days, the two arms looked relatively equalized in terms of average RV function across them. The second trial, which aimed to do this, it's my friend Dinu Balanescu ran it, and I helped him a little bit with it. It was actually run out of Iran, and the only unfortunate thing about it is it was started enrolling in 2019. So because of the pandemic hitting in 2020 and the infrastructure for clinical research in Iran, the trial was halted very, very prematurely. And that's called the Canary trial. The good news is the results were published, but unfortunately it didn't achieve what was hoped for, which would have been a more definitive trial of catheter-directed lysis versus anticoagulation alone and what the risks and benefits were of it. So with it being halted prematurely, largely verified what Ultima said, which was improvements in RV function that were better with catheter-directed lysis than anticoagulation alone. The slight difference is that there was a signal in Canary, which was a bit larger in terms of its total enrollment, despite being prematurely stopped, at least compared to Ultima, that at 90 days, those RV benefits may have still been persisting. And then you come the final trial that's randomized, that's been performed, but is still quite modest in scope. 100 patients randomized to moderate bore thrombectomy now, mechanical thrombectomy versus anticoagulation alone. And that was the STORM PE trial using the penumbra catheter. And that was published in Circulation in November and simultaneously presented at 2 different interventional meetings in both October and November. Once again, the peer-reviewed data on that is primarily demonstrating improvements in RV function against anticoagulation alone. It's still very important data because, believe it or not, in a randomized fashion, despite all these thrombectomy procedures being done, nobody had ever demonstrated that in a randomized fashion yet, again, despite how far the field has gone. So STORM-P did that and did that successfully. And we wait for further data to be published from STORM-P. Some has been presented, but we're waiting for peer-reviewed publications to present some longer-term data on functional status of these patients, the 100 patients who are randomized to penumbra moderate bore thrombectomy versus anticoagulation alone. So that preamble brings us to what you asked for, which was, what is the story with the new interventional trials? And the ones that, and I would argue that STORM-P is kind of kicking off the golden age of PE randomized trials. But the next big 4 trials are kind of where the real meat is when it comes to what we're all waiting for in terms of what we need to learn about properly treating pulmonary embolism in intermediate risk patients, and also trials that I think have the potential to substantially alter guidelines depending on their results. There's 4 big ones coming, and it's not perfectly clear exactly what order they'll come out in, but the first one is definitely clear what's going to be presented first. And the podcast is very timely because it's going to be presented in about 7 weeks at ACC, and that's the HI-PEITHO trial. That's a trial comparing ultrasound-assisted thrombolysis to anticoagulation alone, but it'll be in a nearly 600 patient population with endpoints that are more clinically relevant. It has a composite primary endpoint that includes mortality as the first line, clinical deterioration as the second line, and we should talk in much more depth about what the clinical deterioration endpoint means in each of these trials in a minute, and then recurrent P admission. And that's a composite endpoint that'll be looked at as a primary endpoint. Of course, a host of other secondary endpoints related to functional status, et cetera, will be extremely valuable, will be collected on these patients, and they'll be followed out all the way to a year with a lot of secondary endpoints collected over that time. So that trial has the potential in March to really be the shot across the bow to demonstrate randomized data in a large sense that moves things because of a very clinically relevant primary endpoint. The next trial, again, it's unclear what order they'll come in, but I think the next trial that'll probably come out after that will be what's called PROG 26. PROG 26 is a trial that is being sponsored by the Czech Republic government. And the trial design is actually, believe it or not, basically identical to that in HI-PEITHO in every meaningful way. Number of patients, primary endpoint, the treated arms. The only difference is rather than using ultrasound-assisted thrombolysis with the ECOS catheter in the interventional arm, they're allowing for utilization of what we call so-called standard catheter-directed lysis catheters. These are catheters that don't have any special bells or whistles. They just are simply small sprinklers that disseminate the thrombolytic locally. That's enrolling extremely well based on the conversations I've heard, and I imagine it's going to be soon that we see results on that as well. After that, you've got PEERLESS II. Obviously, that's a trial that I have a fair amount of involvement with, so that's an important disclosure that I'm helping organize and run that trial. And the issue there is that the goal here is to randomize a lot of patients, in this case, up to 1,200 patients. And you're randomizing to large bore mechanical thrombectomy with the Inari device versus anticoagulation alone. So what's different about that in terms of design than the other trials? Why put more patients into it? The main thing that's different is while the primary endpoint is slightly different, you have a 5-point primary endpoint instead of a 3-point primary endpoint that's in the other trials. And it's going to be judged using a technique called the win ratio. We can talk about later if there's interest in it. You may have covered it in other CardioNerds podcasts because it's become very popular in cardiovascular trials. But those endpoints are going to be first mortality and clinical deterioration, and then recurrent admission for PE. So that all sounds kind of the same. But the big difference is in how the clinical deterioration is measured. And we should get into that. There's some distinctions between how the clinical deterioration is measured between these trials. So it's a less sensitive measure for clinical deterioration, we would predict in PEERLESS II than either PROG-26 or HI-PEITHO. Additionally, there will be a non-clinical deterioration-based bailout. So we did allow investigators, if at day 3 a patient was still symptomatic or met a bunch of different criteria, they could cross over. That was to enable for enrollment of a trial in an era where these devices are all readily available. So we allowed for that to happen. And that's the 4th endpoint. And the 5th endpoint is a 48-hour dyspnea score, which will be objectively assessed. And then finally, you come with PE-TRACK. PE-TRACK is an NIH-sponsored trial, extremely important trial. It's complementary to all of the above. The big difference with it is its primary endpoints. It actually has co-primary endpoints. They're being measured at 3 months and 12 months. So at 3 months, patients will actually be getting CPETs, cardiopulmonary exercise tests, examining them for their peak VO2. And at 12 months, they'll be assessed for their New York Heart Association dyspnea classification. In that trial, it's more of a strategy trial. You're not forced into using any particular device as you are in the other 3 trials. If you notice, they're all designed in a way where the specific devices are kind of protocolized and dictated. PE-TRACK, you can do catheter-directed lysis, you can do mechanical thrombectomy, and you can do it with any FDA-cleared device. It's a US trial. And it's just going to be a strategy of intervention versus not, and then seeing a little further down the line how these patients are doing, 500 patients. That also is enrolling extremely well. It's my expectation that this, and why I call this the golden era of randomized trials, is that, believe it or not, we could have all this data by the end of 2027 as theoretically possible. This is a really important couple of years that could really influence how we think about this disease process, how we treat patients, and how guidelines may change. And I'm happy to delve into the nitty-gritty of the trial designs if it's interesting.
Man, that's some serious trial development boot camp for me. I don't know about you other guys, but seriously, thank you. It also helps me understand a little bit more of some of the common critiques of some of those earlier PE studies and RCTs, where we were looking at more specific hemodynamic markers or just RV-LV ratios without a clear focus on what some other folks may say is a hard outcome, or in your case, we're talking more about these composites. As a trainee, and to our fellow CardioNerd trainees out there trying to practice more evidence-based medicine, what do you think are some of the strengths and limitation of these early RCTs, and how do we apply those in the context of all these new trials coming out? And if I'm trying to apply a trial to a specific patient in front of me, am I not really thinking so much about some of these RV-LV ratios or how they're clinically looking in the moment? I'm trying to just figure out how to apply this clinically to a patient.
Yeah, it's a great point. So where we stand now is the following: is that presented a great case of an intermediate risk patient, an RV-LV ratio of 1.2, was symptomatic. There's some other information that we usually would ask, like CT scan, anatomy of where the clot's sitting, just to think through what interventional approaches are. But in reality, the discussion I think today at this moment that you have to have with that patient is really based on the concepts of how are you feeling right now, and do you want to feel better faster? And while we haven't perfectly proven the second piece, we have pretty well proven that RV function and total clot reduction happens more rapidly with an interventional approach. And that's, if you want to know what you've learned from the prior trials, I think you've learned that for sure. The big question becomes, is that enough across a broad range of intermediate risk PE patients to speak further on, if we do this, you're less likely to decompensate right now in the hospital or over the short term. And you're also more likely to feel better at month 3, month 6 down the line. Those are the 2 things we can't say well with the current data. And those are the 2 major questions that I think will be theoretically answered by those suite of 4 very large randomized trials that are coming out. We're going to get tremendous amounts of data on functional status. You can imagine greater than 2,000 patients being randomized with all of these assessments in the secondary endpoints in most of these trials of their functional status long-term, and in the primary endpoint in PE-TRACK with actual CPET studies. I mean, how valuable is that? And the early decompensation piece, what we really need to be looking at is this clinical deterioration endpoint in each of these trials. And why I say I think that's the most important endpoint that really drives these studies. They all have composites, whether you call it, the win ratio is kind of a different flair of a composite endpoint, obviously, but they all have these multi-component primary endpoints. And what I want everybody to focus on really is the clinical deterioration component. When you see HI-PEITHO come out, when you see PROG-26 come out, when you see PEERLESS II come out, I really want you to look at that clinical deterioration. And why is that? Why am I not telling you to look at the mortality? It's because I'm just going to say it right here. I don't have knowledge of the results of any of these trials, obviously. The books are closed until they're opened and presented. But I can tell by the design that it would be absolutely shocking to me if any of them showed differences in mortality in the short term, and frankly, even in the intermediate term. And you're going to ask, why is that? That doesn't make sense. You just told me that you've powered these trials much larger. 600 patients like PEITHO, 600 in PROG-26, 1,200 in PEERLESS II. Why can't you find a mortality benefit? And even if you can't find it in any individual trial, if you put those three trials together, you've got 2,400 patients that you could meta-analyze, and I'm sure you'll find it then. What I'm here to tell you is, and we'll see if I'm proven wrong, because this is going to live forever on the internet, I guess, but I'm here to tell you that's not going to happen. And the reason that's not going to happen is how these trials are designed. The issue that happens in each of these trials is that as soon as a patient starts to show signs of decompensation, they cross over. So this is very different than, let's talk about something you guys have probably talked about before on CardioNerds, something like the history of TAVR. I was involved a little bit in those trials when they were happening very early in my career. If you remember the first TAVR trial, it was a randomized trial and patients were considered non-operative. They got randomized to TAVR in one group, and in the other group, they got quote unquote optimal medical therapy, with many of them getting a balloon valvuloplasty, which we know is something that is not a lasting therapy. And then you just watched them. You didn't get to cross them over into TAVR. It wasn't how it worked, because the FDA, from an approval standpoint, that's an unapproved device, and that's not how, in order to get it approved, you've got to really show what's happening. So what happened? In the patients that were in the arm that did not get TAVR, they basically all died within 5 years, like all of them, 98%. And in the patients who got TAVR, of course, these were old, very sick patients. So there's a lot of mortality there, but it wasn't 98%. Some of them did, many more of them survived 5 years. So the issue with PE therapies is that we have, at the era these trials are being run, we have all these PE response teams. We have a lot of different ways of treating these patients. We have therapies, as was mentioned by you guys, that people feel comfortable a bit with their safety and short-term efficacy profiles. So were any institutions really going to sign up? And did we feel there was equipoise to just watch patients clinical deteriorate in the control arms? No, we didn't feel that way. So we said that once you start deteriorating, you're allowed to cross over. And of course, you could be treated other ways too. Maybe you get surgery, you get systemic thrombolysis. But the truth of the matter is, I think when these trials come out, you're going to see when the crossovers happen, you just cross over to the other group. If you're in a catheter-directed lysis trial, you'll probably just cross over and get catheter-directed lysis if you start to show some bad signs. If you're in PEERLESS II, you'll probably just cross over and get mechanical thrombectomy. So what happens is that in that control arm, you're going to have these patients who are clinically deteriorating, but then they immediately are going to get rescued by these therapies that, again, it was pointed out by you guys, seem to have reasonable safety profiles. So the grand majority, perhaps even all, in some cases, of these patients are going to be rescued, who otherwise, with deterioration, might have 20, 25, 30% mortality rates. You're not going to see those mortality rates happening in the control arm. That's a good thing. I don't think we should be just like letting these patients decompensate and die. That would be so terrible for the sake of some theoretical clinical research. But I just want to make it clear what's going to happen. So what does that do? It's going to make the control arm with that endpoint, which is mortality, that's component of the endpoint mortality, look more like the interventional. So you're going to bias, in trial spook, we call it biasing to the null. So you're going to bias the mortality to the null hypothesis, which is no difference because of the crossover. So that's like a key thing to keep in mind, is that these trials, I would predict, are not going to show mortality differences. It's really important that you don't throw the baby out with the bathwater. And I hate to say this, but I'll try to preempt narratives that I could see coming out later, which is the trial's positive as primary endpoint. And maybe it's even positive for clinical deterioration. I think it's very clinically meaningful. But you may hear some people saying, oh, it's positive for clinical deterioration, but no difference in mortality. So what did we really learn here? That would be a very unfair critique, given what I just told you about the designs of the trial. So again, that brings us back to the fact that I think that clinical deterioration piece is the key piece that we need to focus on in each of the trials. Clinical deterioration is so clinically meaningful. This is a patient who is intermediate risk and they're backsliding to high risk, either hemodynamically or respiratory-wise. They're falling apart on you. That's really important. And those are patients who, if they aren't treated aggressively, do very poorly. So if there's a difference in those clinical deterioration rates between arms that receive an intervention earlier versus just being treated with anticoagulation alone, I think that has some real significance with where the field should go, how guidelines should be written. And that's why I've got my eye really on those clinical deterioration components. The next piece to think about with clinical deterioration is how it's actually measured in the different trials. And again, let's focus on the 3 big trials, not PE tract, which is more focused on 3 to 12 month endpoints, but we'll focus on HI-PEITHO, PROG 26, and PEERLESS II. And remember, HI-PEITHO and PROG 26 basically have the same trial design. So clinical deterioration there is measured with what's called the NEWS score, National Early Warning Scale. It's a scoring system that takes into account a bunch of clinical factors that are in real time, like vital signs, basically. You're looking at heart rates and you're looking at respiratory rates. It's an amalgamated score. And when you look at that score, you have different lines, how sick the patient is at that moment from a critical care standpoint. It was developed to judge patients with sepsis to try to catch when they would be decompensating and need more aggressive therapies. And sepsis maybe means that you weren't catching somebody who's becoming septic, for example. Now they need antibiotics and fluids and all the efforts that you guys know better than me of how to take care of these patients in the MICUs. So that's what it was developed for, I believe, in Great Britain, definitely in Europe many years ago. It's now been kind of lifted from that and applied to PE in these 2 trials. Well, you could say, has it been validated in that, Aaron? It's a very logical way of judging potential decompensation of somebody who's drifting into kind of a shock state or a state of significant respiratory distress. Just like how that can happen in sepsis, that can happen in PE. And these are just objective metrics to look at that. So because it's an ordinal score and you have these, you can move and get different amounts of points. You can have a NEWS score of 6 or 7 or 9 or 4. It's more sensitive at picking it up than just a yes, no of is the patient on pressors or are they not? So I would argue that in HI-PEITHO and PROG 26, the ability to detect clinical deterioration is more sensitive, and they have the potential to detect that very well. We still are going to have to find out if, in fact, they're positive, and we'll find that out again with HI-PEITHO in just a couple of months now. But this differs from PEERLESS II, where it's using just the clinical approach of clinical deterioration, meaning one of 4 factors. Do you have to start pressors on the patient? That's clinical deterioration. Does their blood pressure drop to less than 90 for a substantial amount of time? Usually that also means you're starting pressors on them, but occasionally I guess you could be lower than that for 30 or 45 minutes and get bailed out with some fluids. That would technically be a rare case that would qualify for deterioration. Do you go on mechanical circulatory support, most commonly with ECMO? Of course, that's a terrible deterioration. Or do you have a very significant respiratory decompensation, getting intubated, going onto a non-rebreather when you were on very minimal oxygen before? So that's a different way of looking at things. You can hear how the threshold for meeting those criteria is potentially higher than shifting the NEWS score. I shouldn't say it's higher because where they're drawing the line on HI-PEITHO is they're drawing the line at a NEWS score of 9, which I think is very clinically relevant. That's a pretty sick patient if they're at a NEWS score of 9. However, the ability to detect it is more sensitive in the NEWS score than just the clinical way of trying to pick up these facts that I just told you. It's a little bit more of a blunt instrument in PEERLESS II. Now, PEERLESS II could have up to twice the amount of patients, so it may have the power to detect that, though. But you can see how there's the devil's in the details of how these trials might look with regard to clinical deterioration, number 1. Number 2, you can see why I don't want you to get too attached to the primary endpoints of all these trials, which is mortality.
Thanks for sharing that. I think that was some great insight into clinical deterioration, how it's a trial endpoint, and how important it is to consider it in addition to just mortality. Zooming out for a moment, though, one of the recurring themes in PE is really how challenging it's been to generate randomized evidence. From your perspective, what makes PE fundamentally different from other cardiovascular disease states where randomized controlled trials are perhaps more common?
I don't think it's that hard to generate randomized evidence in intermediate risk PE. The biggest thing is that I think justifies that is that these 4 trials are getting enrolled, right? When these trials are done, that's going to be it could be up to 3,000 patients that got enrolled over a 4 to 5 year period, worldwide randomized in intermediate risk PE. So I don't think it is necessarily difficult to randomize intermediate risk PE patients to do different therapies. They're stable patients. You can go have a conversation with them, consent them appropriately, do what you need to do, and you can design the trial how you want with how rapid the intervention has to be. However, despite the fact that I'm saying that, where are the issues with doing a randomized trial of intervention? Well, I think first has been kind of the support, like who's going to support the trial, who's going to fund it. You usually have 2 groups of funders, and they're both evident in these 4 trials I mentioned. One is government funders. So one of the trials is funded by the US government, one is funded by the Czech Republic, And then you have industry sponsors. So there's two big players in PE. Boston Scientific now owns Penumbra, so they definitely now are truly a big player. And Inari/Stryker, there's industry funders. So those are generally the two ways that trials get funded. So first, there had to be buy-in from those funders that it was in their interest. And they have different incentives and reasons to fund. A government ideally is funding purely because they think that the question is in the interest of the public health and that it's feasible to answer and that it will have major impact on the public health to answer. That's ideally what would drive a government to sponsor a trial. There's no question that industry partners are able to generate evidence that also does that. But obviously, there's business considerations involved with industry as well, that they're going to have to be thinking through, is this the right trial at the right time for our business? At the same time, that they still have to be above board scientifically in order for the trial to pass the muster of folks like you who are going to have to interpret it and decide whether you trust it to change practice. So I think it took a while for the field to mature enough from an interventional standpoint to think that we know what questions to ask. We understand how we might have to power these trials because we have to think through, like, what do we think the effect size is going to be? In order to design a trial, you have to kind of be able to take an educated guess on what the differences in endpoints would be between the two arms. That was fairly opaque for a long time in the field. So the more even observational data that comes out, you start to at least hone in a little bit more on those guesses, which are really important guesses for when you're designing the trials. And then when it comes to interventional trials, especially of the thrombectomy device, you do want to think about the operator experience piece. Do we have enough operator experience where we think we're going to get a valid assessment, an internally valid assessment of how this device works without having to think too hard about learning curve issues, which might inappropriately cause a trial to look negative that otherwise would be positive if we were in a more mature place with the field. So these are a handful of considerations that I think played a major role with what some people might consider a delay for this evidence to be generated. But I think there's another thing that played a major role. And this is something that I've thought a lot about. I've definitely moderated my approach and my thoughts on it. And that is the influence of governmental regulatory structures on the interventional therapies themselves. We'll do the same thing and talk about the difference between PE therapies and, for example, TAVR, which I'm sure you've talked about on these podcasts before. So what happens with PE therapies is the FDA has a set of standards that states that the type of trial that gets an interventional PE device cleared for utilization and marketing in the US is a single-arm study that has a good safety profile and shows an improvement in RV function in a single-arm fashion, a decrement in the RV-LV ratio. And they have a threshold for what they want that RV-LV ratio to come down by that you have to meet. And then you have to not have a lot of complications. And generally, it takes between 100 and 150 patients in a single-arm fashion to give them enough data to clear the device. Probably is in the scope of a different podcast to go deep into FDA regulatory structures to describe why exactly that is. So I think it's beyond the scope of the discussion, but that's what was decided for PE therapies. That's been consistent for every device. You'll see new devices coming down the road. There's been a handful that have been at 510, FDA 510K cleared in the last 6 months to a year that have met those standards, similar to how Penumbra and Inari and ECOS have in the past. And that's very different than what happens, for example, in the structural heart space with TAVR or with MitraClip or with catheter mitral valve or tricuspid therapies that are coming out. There, what's actually mandated was randomized data against the best available therapies. With TAVR, obviously, there was a randomized therapy trial against surgical aortic valve replacement. And the device wasn't going to be FDA pre-market approved for marketing and utilization with a label and indication that says that it could be used in high-risk patients for surgery until it was proven that it actually passed the muster in a randomized trial against her. The same thing was done with intermediate risk patients and low risk patients. Now TAVR is kind of available for the grand majority of patients with AS. So you can imagine how much more rigorous that pathway was. So obviously in the past, I often would think like, wow, that's such a big difference. And it doesn't seem right that you're in this position where therapies are just like getting this free pass and we have no evidence. And now they're just all these therapies out there in the world and they didn't get proven by the type of trials that are being run now. Actually, at that time, 10 years ago, I'd say these trials are ever going to get run. There's no incentive to do it. All the devices are already cleared. So I was coming from the perspective of thinking that the only reason that you could ever do a trial was because it was in the business interests of getting it approved for use. And there's no question that that could be true. And obviously, they set those standards in structural heart therapies, and that's how the field's developed. But in reality, what I think this PE story has taught us is that things are a bit more nuanced than that. In fact, these devices did all get cleared under that relatively lax pathway. I don't think the world fell apart by that happening. Obviously, there was a promulgation of PE response teams, and there's all the debates you guys have, and there's a lot of things happening nationally in the field. And there's a lot of variability in care, I'm sure, from place to place. The utilization of them, especially the absence of kind of clear guidelines and RCTs to guide us. So that latter piece, some people would find to be a relative negative. But what's actually ended up happening? Well, a couple of things. One is there's been a feeding frenzy of innovation. And I would argue a lot more innovation than happened, for example, in the TAVR space, where up until recently, there was a duopoly. There was only 2 valves on the market for a decade plus. They were effective valves, but is that duopoly good? Well, there's some negatives. That allowed the valve prices to stay at $32,000 a valve, which is major strain on a lot of hospitals and has an impact on public health when things stay at that pricing for so long. So the barriers to entry were so high for a new competitor. So the third competitor has just come to market more recent. And now there will hopefully be others. But look how long it's taken. The first SAPIEN valve got approved in 2011. So we're 15 years before we have a third competitor on the market. But in the PE space, we're going to have a whole host of competitors on the market. And they're going to have a lot of different attributes to them. So a feeding frenzy technologically to try to build a better mousetrap and try to compete. And that competition maybe allows us to do more safer, effective procedures. And it certainly creates maybe some more favorable economics as the field matures. That's a positive. And then the second piece is that did the RCTs end up happening? It turns out they did. And they happened. And I thought, well, if they're going to happen, the only chance they happen is if the NIH funds it, which did happen, which is great. And great for the Czech Republic also. So it's great the government stepped in. But look at that. What also happened, which definitely was wrong about 10 years ago, is industry stepped up, specifically Boston Scientific, Inari, and Penumbra as well to an extent, and all stepped up and ran trials as well. So why would they do that? They already have cleared devices. They already have devices that have pre-market approval. Well, they did it because they have to, right? Because we're talking about this, because you don't know how to manage that case that you just presented to me at the beginning. And even if you have an opinion on it, the guy in the hospital across the street may have a different opinion. So in order for their devices to actually reach the market that they want them to reach, the market ended up forcing them to produce randomized data. I just think it's important to think through this when you think of different ways technologies coming out, that there's some technologies that have come out with certain evidence development strategies that are forced by the regulatory apparatus in either the US or the EU. There are these others which evolved far more organically through market forces. And these days, I think there's pros and cons. There's a tension that makes me think it's not totally clear to me which one is truly superior. And that can be something that's maybe a bit of an iconoclastic take.
Goodness. One other thought I was having when you were talking about some of the limitations between, say, the general cardiovascular trials, and you were specifically talking about TAVR and these pulmonary embolism patients, was kind of the heterogeneity and the triage. And I'm curious if, for instance, if you were to use the ESC triage and the guidelines to look at 2 different patients, they may both meet the same criteria, but look clinically very different. How does that heterogeneity complicate trial design and enrollment, specifically, like, say, with selection bias?
So specifically, I just want to make sure I understand the question. You're talking about heterogeneity of the patients who are included in the trials?
That's right. I mean, if you have, say, someone with serology, elevation, RV-LV ratio that's elevated, and a nice central clot burden that's reasonable for thrombectomy, but they may look very different. One person's breathing 35 times a minute, it's on 5 liters, and the other one's sitting on 1 liter and talking on their cell phone.
It's the most important point is that the trials are going to get done, and you're going to need to use your clinical judgment. And that's true of all trials. I would discourage anybody from reading a trial in the New England Journal, looking at the conclusion line and saying that the title said this, the conclusion line said this, so this, I'm going to treat all these patients from now on. That, I would argue, is definitely not the best way to practice medicine. I think what you mentioned is the key, is you're trying to think through, what did I learn from the trial that taught me more about the pathophysiology of the disease? Did it through a randomized clinical trial framework, but I understand this disease in a deeper level so I can tailor my appropriate recommendation to this patient at this time. And to your point, the trials that are getting done, actually the 4 trials we mentioned, have an interesting spectrum of illness within them, although they're all intermediate risk PE patients. So when you stack them up 1 through 4, HI-PEITHO is going to represent the sickest patients. These are patients who are intermediate high risk by ESC criteria. However, they're substantially enriched. They can't just meet those criteria. They also have to have elevated heart rates or relatively low blood pressures and or respiratory rates that are way up. So it's an enriched population. that's going to be the trial that has the sickest patients. And it's one of the things that made HI-PEITHO probably take a bit longer to enroll. The enrichment criteria make it so that not every intermediate high-risk PE patient that walks through the door qualifies. The reason for enrolling an enriched population is kind of similar to what we mentioned with the TAVR trials before, is that if you can prove your device works in higher end patients, maybe you can march your way down later, depending on what's appropriate or not. So in order to find out for the proof of principle, it makes sense to try to target the patients who are at the higher end of risk of those who are currently being recommended by guidelines for anticoagulation, which is what I think has, at least on paper, has done a nice job of doing. We'll see who's actually in the trial, obviously in a couple of months when they report out results. When you go to PEERLESS II, that's one step down, still an enriched population. The enrichment criteria are not quite as stringent as they are in HI-PEITHO. They're similar, but they're not quite as stringent. Again, why is it in PEERLESS II that we didn't make them as stringent? Well, with PEERLESS II, we said that we want to enroll faster. HI-PEITHO was already enrolling, and we said we want to enroll faster. And if we're not making it as stringent, though, once again, similar to how we made the endpoint not as sensitive, the deterioration endpoint, we also made the enrichment criteria a little looser. We try to make up for that by making the trial larger. So we have ideally more power to detect things, even in patients that are maybe slightly less sick, still intermediate high risk and enriched. Then you go to PRAG 26, which the methods paper's published. And I think from what I can tell, I think it's just a pure intermediate high risk population that's not enriched. But you guys may have to go back and read that methods paper. It was published very recently in one of the European cardiology journals. And then finally, you have PE-TRACT. And PE-TRACT is very permissive. Believe it or not, PE-TRACT, you don't actually even have to meet intermediate high-risk ESC criteria. There will be intermediate low-risk ESC patients in PE-TRACT. So that's very permissive. Now it's asking a different question. It's asking for longer-term functional follow-up, including with CPET. So you could argue that you're really trying to evaluate what the consequences of residual pulmonary vascular obstruction are more than anything. So maybe expanding things to try to understand that is in the interest of the trial. It certainly is in the interest of enrollment. It makes it easier to enroll if you have more patients to choose from. So I think that trial is enrolling well and will complete probably much more rapidly than the average NIH trial, which is great. But it is going to be a much looser population. Some of these harder endpoints, I would be quite shocked if they were like earlier hard endpoints, especially if they were positive. And PE-TRACT, because it's almost kind of not designed to detect that when it's looser criteria. At the end of all of this, you'll have 4 trials that actually did enroll somewhat different populations of patients. And although I have my thoughts on what you're saying now, I think now is that it's those patients at the higher end of risk who are quite symptomatic. That first patient you just alluded to, who's breathing 30 times a minute and can't walk to the bathroom. And maybe they've made some lactate, really bad sign, I think, that they're having end-aortic hypoperfusion, normotensive shock. Those are the patients that I'm tending to be more aggressive with. I'm perfectly happy to enroll that patient in a clinical trial. I think there's equipoise to do so. But presuming I'm in a hospital without clinical trial capabilities, I'm going to be thinking really strongly about intervening on that patient. That healthier patient, I'm not acting that aggressively on now. Is it possible that could be altered by these trials? It is. But I think we'll have a more granular understanding of it about a year and a half from now, maybe 2 years from now, when everything's reported out because of the differences in populations being enrolled.
Dr. Giri, now that we've addressed this question of heterogeneity and how the latest trials are compensating for this, what do you think it'll actually take for the guidelines to change? Do you anticipate that these new trials like HI-PEITHO and PEERLESS II will be enough?
Yeah. Well, it depends. Obviously, there's guidelines are a moving target, and there's many different guidelines in PE. So there are guidelines from many different organizations, European and the US, and different specialties. Whether pulmonologists, whether multidisciplinary like PERT, or the European Society of Cardiology, whether the AHA, there's all kinds of groups that are in the mix. So when we say guidelines changing, I think the question first will be like, do guidelines all change together? And that'll be interesting to see. But then the second piece, I think, will be what moves guidelines. And I think there's no question in my mind that these 4 trials are designed in a way that they should be able to move guidelines. Because if guidelines right now are not reflecting the knowledge that's known, I mentioned to you that there are some, Ultimo was done a long time ago. Canary was done a while ago as well. They were randomized. Then you mentioned all the observational data, you alluded to it. And none of that moved guidelines to really give any kind of real position of primacy in intermediate risk PE to interventions, right? So I would argue that what guideline writers are waiting for is harder clinically relevant endpoints, which could be early clinical endpoints like we mentioned, or things that are very relevant to patients. Perhaps patient functional status will move guidelines, but I would almost guarantee that hopefully things like mortality and clinical deterioration will move guidelines. But perhaps patient-centric metrics would as well. But both of those categories are very different than imaging surrogates, which is where the old trials were stuck with. RV-LV ratio, T-scans sometimes reduce clot burden, sometimes PA pressure reduction, so hemodynamic surrogate. So very different.
Now, Dr. Giri, while large-scale RCTs provide the high-level evidence we need, the real-world execution of these protocols often happens at the bedside through multidisciplinary collaboration. So this brings us to the pivotal role of pulmonary embolism response teams in bridging the gap between clinical data and clinical practice. So how do you envision the evolution of PERT programs within this landscape, and beyond their role as multidisciplinary care models, how can they be leveraged as centralized engines for pragmatic clinical trials to accelerate the generation of real-world evidence in PE?
Yeah, it's going to be interesting to see how things evolve. So right now, one of the major pushes for pulmonary embolism response teams over the last decade and a half has certainly been that we're in this world where we have a lot of options for how to manage these patients, between discussions around anticoagulation, systemic thrombolysis, interventional therapies, mechanical support, IVC filters, you name it. And much of it is not totally fleshed out from an evidentiary standpoint, as we mentioned. So the concept of this coalition of the willing and folks who wanted to become experts in their local hospital, PE, taking on the mantle of thinking through this and in a way that's not completely independent has been very popular, I think, with good reason. One question that often arises is, if evidence becomes clearer, especially over the next couple of years, what cohorts of patients more cleanly deserve therapies, then does the role of the PERT team change a little bit? When I look at that, I sometimes think about something like acute stroke or perhaps acute MI. And in those cases, there needs to be a lot of coordination of care from a health system level and even from a community level to appropriately deliver the care to the patients with the acute cardiovascular condition. But some of the issues with how to deliver that care are more about what you kind of alluded to there, which is systems of care delivery, as opposed necessarily to debates over what's actually going to happen. And you can see how that's a little bit of a change. One is about trying to make a decision around clinically what the appropriate course of action is for the patient, which is kind of where we've been largely PERT teams. Whereas the second is really heavily focused on how do we deliver the care that we know should be delivered in the most efficient way possible to improve the public health. So it's almost like a second phase of a field's development when you're hitting that second piece. And I think PE's kind of hitting that now. I think that's what we're going to hit over the next couple of years, is that we need to transition as a field to moving more into that second phase. And I agree with you, what your kind of the conceit of your question was, where you talked about real world evidence. That's where real world evidence, I think, has more of a role. I would be extremely cautious about using somewhat euphemistically termed real world evidence by CMS, FDA, et cetera, for comparative effectiveness analyses, regardless of how much you try to adjust or what somebody tries to tell you, because the confounding is almost always irreconcilable. And depending on the data sets that are used, there's often fundamental flaws in those data sets and trial designs and covariate definition that end up compromising, I should say, what we call causal inference. So the idea that what you think you're learning in terms of comparisons between therapies from a given data set, that though you think you're learning something is true, it may or may not be true. And that's where I think the randomized trials are far more effective at providing you that comparative evidence. But I think where real-world evidence has been shown to be really effective is in trying to help us move to that second phase and then see how we're doing. With MI, you can see that there's a thought that all these hospitals would get together and collect evidence around how they're doing on providing MI care. Early are they getting their patients to the cath lab and getting the vessels opened with door to balloon times? And how are we doing with administering statins and aspirin and beta blockers, although that's obviously a bit more controversial right now for uncomplicated MIs. But historically, how are we doing with these evidence-based therapies in the acute MI patient? The real-world evidence enables you to demonstrate whether you're doing well, whether there's heterogeneity in the instances where there should not be. And remember, if data heterogeneity itself is not necessarily a bad word, I think it's only bad if something is likely to be good. If you've proven something should be done, then heterogeneity is probably bad. But if you haven't proven that, then heterogeneity itself is not necessarily bad. Maybe it could be revealing, learn something from it. But you end up finding that, and then you end up maybe being able to pin down if there's a reason for the heterogeneity. There's a given area or hospital or region where something doesn't work well, maybe you could identify that using real-world evidence and population-based evidence, go and address it. So I think that PERT teams, real-world evidence generation, has a potential major role going forward in all those ways. And that's something that I think is very much following in the footsteps of what we've seen most recently with stroke and in the past with MI.
This has been an incredibly rich discussion, and I just wanted to synthesize a few take-home points for our listeners. First of all, for years, advanced PE therapies were driven largely by physiology, registries, and single-arm trials. As we learned, we're now entering a new era where randomized controlled trials like STORM-PE, PEERLESS, HI-PEITHO, and PEERLESS II are finally testing these therapies more rigorously. Secondly, conducting RCTs in PE remains challenging, as we saw, due to heterogeneity, endpoint selection, and equipoise. But the bottom line is that the pipeline is stronger than ever, and the future of PE care is likely to be more evidence-driven, personalized, and patient-centered.
Now, Dr. Giri, before we wrap up today's masterclass in the PE studies, we have one last question for you. In true CardioNerds fashion, what makes your heart flutter about pulmonary embolism studies?
Yeah, that's a good question. I think that the biggest thing about the landscape is exactly what we just talked about. This is an area, and just said it, you've got actually the 4 randomized trials we mentioned. You've also got STORM-PE that's completed, PEERLESS I that's completed, and you also have PEITHO 3, which we get to talk about, non-interventional trial, which is going to be valuable, and 2 high-risk randomized trials, which are actively enrolling, which are crazy difficult to enroll, PERSEVERE and TORPEDO-NL. So if you think about it, what we just talked about, what I just summarized there is how many trials that are randomized novel evidence. That's like 8, even 9, it's somewhere in that range. So is there any other subfield, cardiovascular medicine or medicine at large, that has 8 RCTs enrolling comparative questions in distinct populations of patients over such a short period of time? I'm almost certain the answer to that is no. So I think it's a pretty obvious thing that should have everybody's hearts fluttering, lungs expanding, et cetera, is that the total amount of evidence generation effort in this field is completely unparalleled and is like at the absolute top of the list in terms of anything happening in medicine internationally right now. I think that's the best part about the field.
Sir, I don't think we could agree more. This has been another fantastic addition to our ongoing pulmonary embolism series. Dr. Giri, thank you for your expertise and time. I'd like to give a special thanks to my fellow co-chair and our fit lead for all their hard work. CardioNerds, thank you for joining us in this discussion. Be sure to check back in to catch the rest of our series as we continue to break down the management of pulmonary embolism with an array of international experts. See you next time.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Julia Marques. I am an intern in the CardioNerds Academy House Thomas, and I'm a 6th-year medical student at Albert Einstein University in São Paulo, Brazil. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.